good morning, everybody. Thank you for joining this talk this morning. I've been asked to do a talk on COVID diagnostics. So I'll be giving you just a brief overview of the tests available and interpretation of some of these results. My name is Howard Newmann, and I'm a clinical virologist at Pathcare based in Cape Town. Okay, so after the intro, I'll just briefly touch on PCR, some of the technical issues around that. Of course, we have antigen testing available as well, and then we'll look at antibody testing and how to interpret some of these results. And then we'll tie it all together at the end. Okay, so as you know, last year was just completely shambolic. I'm sure for everybody on the front line as well. But in the lab, I tell you, it was a nightmare. We were completely overwhelmed. All labs around the world, I suppose. It was literally a shock to the system. We had new tests we had to validate. We had to work on workflows to deal with the specimen numbers. And as you know, we had massive testing backlogs, sometimes up to a week to get a PCR result. And of course, these new assays, we didn't have much experience with them at the time, but thankfully that has all changed now. So we've got several testing options available, from molecular testing to antibody testing to antigen testing. And we've got some good experience with these tests now. So we are much better equipped, not only to interpret some of these results, but to deal with demand as needed. So in virology, we can detect viruses directly or indirectly. Direct detection would be things like PCR, as well as antigen testing, because you're directly detecting a piece of the virus. Of course, testing for humoral immunity would be a form of indirect detection, which obviously has its several uses in clinical medicine. There are other indirect immune responses one can test for, such as cellular immunity, but that's not widely available. Okay, so let's look at the PCR, polymerase chain reaction. I'm sure some of you are experts in this by now. It's always worth going over it again. So PCR is a molecular test, and the point of PCR is to amplify genetic material so that you can then detect it. So it's very sensitive because it relies on amplification, and it's very specific because you are using primers. So if you can see my cursor, these red pieces here are your primers. So primers are also small pieces of genetic material that are specifically designed to bind to the target of interest. So if you, for example, want to amplify a piece of the nucleocapsid gene of COVID, you know the genetic sequence, you can design a primer to bind specifically to that sequence. So that's where the specificity comes from. Then there are other reagents in the PCR reagent mixture, such as your enzymes, your polymerase, and as well, and probes as well, which we use to actually detect what we're amplifying. So in essence, if you start with one copy of genetic material here, one piece of double-stranded DNA, you go through this, what we call the cycles of PCR. So the first step in the cycle is to denature the double strands into single strands. That allows your primers to bind. That's called annealing. And then your polymerase enzyme comes in and makes a new double strand. That's called elongation. Okay, so you can see you started with one double strand, and you've now ended with two double strands. So you doubled what you started with. After another round of PCR, you would have 4 copies. So you can see you're getting an exponential amplification because you're doubling what you started with from the previous round. Okay, and that's what makes PCR so powerful, sensitive and very specific. So we can either do manual PCRs or we can do fully automated PCR. So the first step in any PCR is to extract nucleic acid from the sample. Okay. So we can do that with a manual extraction, where you're physically pipetting samples, which can be quite cumbersome. Or we have these fully automated extraction instruments as well that can extract the nucleic acid for us. Once we've got that nucleic acid extract, we can then amplify it using the cycling of PCR. And that can be done on thermocyclers, such as the ones you see here. These are benchtop thermocyclers, and they can process about 96 samples at a time. And predominantly, these are the instruments we're using to get through the bulk of our work on a daily basis. So it requires a separate extraction and then separate PCR amplification. The alternative is these fully automated fancy instruments, which are quite large. We do make use of them as well. So we've got a nice repertoire of different tests that we have at our disposal. So in these large instruments, everything is happening fully automated in a closed system, and it reduces your risk of contamination. So yeah, there's lots of different types of platforms out there. So I'm sure by now you've all heard of CT values. I'm sure some of you have phoned for the CT value. CT values can be useful, but they can be problematic as well. So the CT value is a cycle threshold for a particular specimen. So you'll only have a CT value if the result is positive, if something was detected. If the result is negative, there'll be no CT value. So the CT value is, so like I've said, there are cycles of PCR, and typically we do about 40 cycles. So the cycle at which fluorescence is detected above a predetermined threshold, that is your CT value or cycle threshold. So at the point where this graph crosses that line, if that happens to be cycle number 20, then your CT value is 20. So obviously, if your CT value is higher, the viral load in that sample is much lower. If your CT value is lower, your viral load in that sample is much higher. The fluorescence comes from the probes that we use in real-time PCR. So there are some issues with PCR. I'm sure you've heard that you can get false positive and false negative results. False positives are quite rare because, like I said, the test is very specific. Yes, you can have contamination in the lab, but if it's an accredited lab, we usually have very strict QA procedures that mitigate against that. But negative results are the problem. We estimate about 30% of clinical false negatives. So 30% of the time, a negative result could be a false negative. And the reason for that is not the PCR. The PCR is extremely sensitive. The issue is the heterogeneity of the sample. So by chance, someone could put a swab into the nasopharynx, and by chance, you could just not pick up enough viral genetic material. Also, if the sampling technique was incorrect, then obviously your sample quality is not going to be great either. So clinical false negatives are quite a problem. The other issue is that because the test is so sensitive, many patients will remain positive for months. So they could have had COVID 3-4 months ago, and the PCR can still be positive at a low level. That creates real problems, especially for people that need to be admitted to hospital or for travelers, because we don't know if they are still, we can assume that they're not infectious anymore, but in the absence of a history of confirmed COVID infection previously, it becomes difficult with these low positives. Of course, people have been complaining about the price of PCR. Unfortunately, that's been set by the Department of Health. But the reagents for these things are very expensive. So unfortunately, that obviously gets transferred to the patient. And then during a peak, of course, I'm sure you've experienced it, you can get long turnaround times. Of course, it's much better now that all the labs have their workflow issues sorted out. But during a peak, you can wait up to 48 hours for a PCR result. So the turnaround time, especially during the peak, what people who are not familiar with the lab environment don't often know about is the pre-analytical issues. That's where most of the time goes in. So if you get a batch of samples all in one, that sample needs to be sorted. It needs to be batched, it needs to be processed, a swab needs to be cut, the viral transport medium needs to be pipetted, then you need to extract the nucleic acid. So that all takes a lot of time. Then, of course, there's the analytic time. So this can vary between 5 hours to 1 hour, depending on which instrument or assay you're using. Post-analytic, there's time involved there as well, depends on the amount of specimens and whether you're reviewing those results manually or automated. Okay, so how do you interpret these results? We report our results qualitatively. In other words, we tell you positive or negative. Some labs I know do give you the CT value, which is a semi-quantitative result, but we've chosen not to give you that value. Yes, you can phone us for it and we'll give it to you. But the reason we don't report it is because there's real risk in using that value for making clinical decisions. And I'll explain why. So if you get a positive result, what does that mean? It means we detected the genetic material. Whether that person has active infection or is infectious, we can't really tell, but we can be guided by the CT value. If the CT value is very low, in other words, the viral load is very high, then of course it's most likely that the person has an acute infection and is infectious. I've put the schematic diagram of the genome of SARS-CoV-2 up top here. So generally our PCRs detect multiple targets, either 2 targets or 3 targets. So when the viral load is very low, we'll usually get a single target only. So like I said, that becomes difficult to interpret because that could either be acute infection where the viral load is still going up, or it could just be old infection. So one really has to look at the whole picture when one tries to make any conclusions. A negative result means that we could not detect any genetic material in that sample. Doesn't necessarily mean the patient doesn't have COVID. So if someone has all the classical symptoms of COVID, but has a negative PCR, then obviously you should retest. Okay. So these CT values are semi-quantitative, as I said. It's not standardized. That's the other issue. So you can't compare CT values between assays and even within the same assay because of the sample issue, the heterogeneous nature of the sample. You could have falsely low viral loads if the sample wasn't collected properly, for example. So it becomes tricky to try and interpret these CT values. Because if you, let's say you did have a high CT value or low viral load, you could have, that could be old infection, where the patient's not infectious anymore, or it could be a new infection, where the viral load is still going up. Conversely, it could be a new infection with a falsely low viral load. So it can become difficult. The one thing you could do to try and troubleshoot these low positives is to repeat the PCR in 1 to 3 days. And if the CT value is coming down, then that's quite clear that the person has an acute episode. But if the CT value stays the same or it's going up, then it's most likely an old infection. Okay. But like I said, these things can be very tricky to interpret. So if your CT value, just to summarize the CT values, if your CT value is low, for example, less than 30, we generally consider it a fairly low CT value. That means your viral load is high and likely this is a recent infection and likely still to be infectious. If you've got a high CT value, about 55, especially if it's single target, then that tells us that it's a very low viral load in the sample. So most likely, we've noted that this is usually previous infection, but you can't prove it because this could still be a new infection when the viral load is going up. And it could be an acute infection with a falsely low viral load. And that's why I say it's tricky to use these CT values to make clinical decisions. The other problem with PCR is the precision of the test when the viral load is low. This often results in discordant results. So with any test, when the viral load is low, the repeatability is also low. So I've just given you a snapshot here of the package insert of one of our assays here at the bottom, just to illustrate what I'm talking about. So here's the concentration of target that they validated. There at the bottom is the lowest concentration, and that is just about at the limit of detection for the assay. That sample with that concentration, they repeated 24 times. Only 6 times it came out positive. The rest of the time it was negative. So you can see that the repeatability is low. So if you have a low viral load, you test that person today, you test them tomorrow, it could most likely will be negative. Even if you test on the same sample, it could be negative. But unfortunately, even those low ones, we as the lab have to report them as positive if we get it as positive, because we don't know at what point in the infection they could possibly be. And that's why it's up to the clinician then to decide, based on the history, whether they had confirmed COVID or not previously. So we get complaints often, especially from travelers that tested positive today and then tomorrow they're negative, and they're going to blame the lab for false positives. It's not a false positive, it's just a low viral load with poor repeatability. Then just some examples of PCR raw data. This is just from one of the assays that gives us nice graphs. So this is the type of graphs we look at on a daily basis. This happens to be a negative test. So with PCR, we have different controls to make sure that we're giving the quality results. We've got negative controls, positive controls, internal controls. Okay, so the graphs you see here are all the controls, and they all worked fine. But for the target, which would have been a green line for N gene and a blue line for RDRP gene, they were not there. So this is a negative test. Here you can see positive test, but this you can clearly see is a fairly low positive. Here the green line for the N gene is coming up quite late. So with a CT value of about 35. All the controls worked, so that was fine. So this was a positive, but a very low positive. If you had to repeat this test, you probably would have gotten a negative. Here's a stronger positive. Here, 2 targets are detected now, the blue line and the green line, RDRP and N, both coming up with decent CT values, fairly high viral load. Here's one that's even stronger positive. This patient is obviously highly infectious in a very acute stage. CT values under 20, nice sigmoidal graphs, and yeah, very strong positive. Okay, and that's PCR. Then we'll move quickly on to antigen testing. It requires the same specimen for PCR, that's a nasopharyngeal swab. Essentially, that swab goes into a little buffer, and then that sample gets ejected onto the sample pad here. The sample then moves via lateral flow through capillary action through this device. And if antigen is present in the sample, it will be captured by antibody at control and test line, and you get a line appearing. Okay. These antigen tests, they're not the best, but they do have some uses. So especially in symptomatic cases during a peak, okay, that's when they are really, that's where we use it. You can use them for things like high-risk groups in communities, ports of entry. I know they do a lot of these testing at the airport as well, and contact tracing. But for us, we use it primarily in a hospital setting where you're potentially expecting a delayed PCR turnaround time. So then it becomes useful, but only in symptomatic cases. And that's because the test is very insensitive compared to PCR. Okay. So if the antigen is positive, that patient has COVID. We know that because the test is very specific. We have had 1 or 2 cases where the antigen was positive and the PCR was negative, but that's extremely rare. But using this test in an asymptomatic person is pointless in my opinion, because your sensitivity drops to about 30%. So what's the point of testing? So we only do it in symptomatic cases in a casualty setting during a peak. And if that test comes back negative on that person, you have to reflex the PCR, because we've seen a lot of discordant results where the antigen is negative and the PCR is positive. Yeah, and then in a low prevalence setting like we are now, outside of the peak, very little value, because the negative predictive value of this test in a low prevalence setting is very high, which means that if you get a negative result, you can trust it, most likely negative. But the sensitivity in an asymptomatic person is just too low, in my opinion. So I would rather just do a PCR. You want your most sensitive test in a low prevalence setting. So obviously antigen testing has its advantages. It's rapid, it's cost effective, it's easy to perform. No need for expensive equipment, but the big issue is the sensitivity. And outside of a lab environment, you have quality assurance issues. So you have these fly-by-night labs, you have pharmacies doing these tests. You've got no clue if they are adhering to quality assurance processes that we do inside of a lab environment. So yeah, it can become problematic. So one of the reasons why it's not as sensitive as PCR is it has a very limited window of being positive. So you can see PCR, you can get positive PCR pre-infectiousness or post-infectiousness, whereas antigen is quite a narrow window. Okay, then we'll quickly move on to serological tests. Here we're talking about antibody testing. So there's different types of ELISAs available, different formats. You get indirect, direct, sandwich. Most of our ELISAs are the sandwich method, which gives you more sensitivity. Essentially, it involves antigen binding to antibody with a conjugate antibody, which gives up a signal. So if there was no antibody, no target antibody in the sample, this step wouldn't happen and you'd get no fluorescence being emitted, and that would give you a negative result. If the antibody is present, it will bind to its capture antibody or antigen with the end result of some sort of light being emitted and detecting that antibody. So for COVID, we've got several antibody tests available. Obviously, we can test for antibodies against the spike protein on the surface of the virus, as well as the nucleocapsid protein, which encapsulates the genetic material. There's been lots of studies about the antibody response to COVID. And this was one of the nicer ones, and really highlights some of the issues in interpreting these test results. So the big problem here is that the antibody response to natural infection is very heterogeneous. People's antibody results don't always conform to what we'd expect. So what I mean by that is some people will produce no antibodies, even though they were infected. Some people will only produce antibodies to N or to spike, and some will only make IgM or IgG. So it becomes very difficult to then interpret. In addition, some people produce IgG before IgM, which nullifies the usefulness of IgM. So it becomes very, very difficult. In terms of the peak concentrations and positivity, you can see your IgM generally will be positive after 2 weeks. Same with IgG. And then your peak concentrations for IgM happens at about 4 to 5 weeks, for IgG about 9 weeks. So if you test too early, obviously you could get a false negative, or even if you test too late, when these antibodies start waning, you could get a false negative as well. Very importantly, is that if you've had mild or asymptomatic disease, the chances are that your antibodies are going to wane very quickly. After 4 weeks, it will probably be negative again. And this is why we tell people who've been infected with COVID that they should get vaccinated, because you don't know if you're in this group. You could very well have had very mild disease with antibodies waning to undetectable levels very quickly. And this is one of the reasons why it's advisable for everybody to get vaccinated, even if they've had COVID. So the more severe disease, the higher antibody concentrations you produce, and they stay in the system for longer. This is the spike protein of the coronavirus. On top here would be your receptor binding domain. You can see there's lots of key amino acid positions there. So one of the concerns with antibody testing was, could the variants give you a false negative antibody test. So we haven't seen that. Every time a new variant is come, the antibody test has still worked. And the reason for that is, even though you have one or two key mutations, yes, you may affect the affinity for that particular epitope, but remember there are usually multiple epitopes. So your overall avidity might not be affected and will still give you, will still allow you to then detect antibodies. So yeah, we haven't seen an issue with variants and antibody testing. In terms of the uses of antibody testing, one can obviously use it to diagnose COVID retrospectively. Someone who's recovered from a COVID-compatible illness and had a negative PCR. And then there's also other very specific clinical uses, for example, children or adults with multi-system inflammatory syndrome. So here, the PCR will often be negative, and often the only thing linking this condition to COVID would be a positive antibody test. So very useful in that setting. And then, of course, for research purposes, seroprevalence studies, etc. And recently, the S antibody has become available. Like you all know, it's a quantitative test, and we can use that for vaccine response. I put that in an asterisk next to it because it's actually not advised to do post-vaccine testing, but it is available, and there are some clinical settings where you will want to test for vaccine response, such as people with immunosuppression. So there's different testing options available, different automated platforms. We currently use the ABIT platform. We've got an N antibody assay, which you can use for for previous infection. And we've got the S antibody, which can also be used for previous infection, but obviously for vaccine as well. And then we've got an IgM assay as well. This is just a picture of one of the platforms we are using to do COVID serology testing. It's a fully automated serological instrument. So some of the pitfalls of antibody testing. A negative serological result doesn't rule out previous infection. Like I've said, some people never produce antibodies. It also doesn't prove vaccine failure, okay, because you could have T-cell immunity. A positive nucleocapsid IgG doesn't indicate protection from reinfection, but also doesn't discriminate between neutralizing and non-neutralizing antibodies, and it doesn't exclude infectiousness. If you have a positive S IgG, it doesn't guarantee protection from infection, as I've said, and the exact correlate of protection is not known. So yes, we give you a value, a quantitative value, but we don't know what the correlate of protection is. We don't know if a value of 1,000 gives you the same protection as a value of 40,000. That's going to come with time, figuring that correlate of protection out. If you have a positive IgM, that unfortunately doesn't prove acute infection. These IgMs have been shown to be detectable for months afterwards. And likewise, a negative IgM doesn't rule out an acute infection. And of course, timing, I've mentioned it already. If you test too early or too late, that can affect the result. So I'll end it off there. I think I've shown you that testing can be quite complicated. There are different phases to the testing, pre-analytic, analytic, and post-analytic, and that's where the pre-analytic areas where a lot of time goes in. Analytic phase can obviously be very technical. And then PCR, as I said, very sensitive and specific. It is the gold standard, but it is a complex test technically. And just keep in mind there's a high rate of clinical false negatives. And it's not due to the test, but due to pre-analytical issues. Antigen testing really only useful during in symptomatic patients and during peaks. And ideally, if it's negative, you should reflex the PCR during a peak. Antibody testing, the response is just so variable in people. It makes interpretation of these results difficult. So you're more than welcome to call us to assist with that if need be. And yeah, moral of the story, whatever result we're talking about, PCR, antibody, antigen, take the whole clinical picture into consideration, and if in doubt, retest. These things can be complicated, but yeah, we're here to assist. If there are any questions, I know there's going to be a question and answer session afterwards. You're more than welcome to ask any questions. And if I don't get to them during the conference, you're more than welcome to email me as well. We're always available to assist. Thank you.